Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm a clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Samuel Holworth. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I am especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. Here is a review from Mamak Shakib, who says, Thank you. Your podcast is a wealth of information. I listened to it while driving to and from work and wished I could take notes. I am so proud of your work and the work of my research colleagues for the advancement of chiropractic and to scientifically prove the very essence of chiropractic. Keep up the great work. Well, thank you, Mamak Shakib, for your review, and I look forward to sharing your iTunes review in a future podcast. Please consider making a contribution to chiropractic science to keep these podcasts going. You can do so on our website either by making a donation or by purchasing the evidence-based patient education slides presentation at chiropracticscience.com. All right, on to the podcast. Well, let's get on to the interview with Dr. Samuel Holworth. Dr. Samuel Holworth is an associate professor, director of human performance research, and the McMorland Family Research Chair in Mechanobiology at the Canadian Memorial Chiropractic College. He also holds adjunct positions at Ontario Tech University, University of Toronto, and University of Guelph, as well as Memorial University of Newfoundland. Dr. Howarth obtained his PhD in kinesiology from the University of Waterloo in 2011, focusing on biomechanics and more specifically related to the spine. His current research is directed toward biomechanical analysis of human movement, focusing on functional tasks used in daily life and clinical practice. A fundamental component of this work and scientific inquiry in general is measurement and data handling. Once a topic primarily relevant to researchers, the proliferation of low-cost sensors capable of providing clinicians with a seemingly unimaginable amount of data extends the conversation on the acquisition and interpretation of measurements to the clinical environment. Well, Dr. Holworth, it's my pleasure to have you on the Chiropractic Science podcast.
Thanks for inviting me, Dean. I think that we're going to have a little bit of fun with this today.
Absolutely. And measurement is such a cool thing, and there's so much to talk about. But as I do with all of my podcast interviews, I'd really like to get started with getting to know a little bit more about you. And first, I'd like to thank you for inviting me to speak to your research group at CMCC this spring.
Well, quite frankly, Dean, I should be the one thanking you because the students really enjoyed that session, and I feel that they got a lot out of it. You know, before we really get into things, the pandemic has actually been beneficial in some ways for doing these kinds of activities. And, you know, we've been fortunate to invite speakers from all around the world and expose them to the CMCC students, which obviously would not have been something that would have been possible in person before the pandemic.
Yeah, for sure. I mean, there are definitely some good things, exposures to technologies that we're going to be talking about today, and having a chance to play with some of these things as there's a little bit of lull in the way things have typically been done. We find new ways to do things for sure. Well, Sam, how did you become interested in biomechanics of the spine and subsequently, pursuing your PhD at the University of Waterloo?
Yeah, it's an interesting question, Dean, and it's a bit of a story. So I managed to do my undergrad, master's, and PhD all at the University of Waterloo. Part of my undergrad was a joint honors between mathematics and kinesiology, and what that entailed was regular meetings with the undergraduate chair in the kinesiology department, because this was something that hadn't necessarily been done before. conveniently, that person was also the professor for our research methods course. And he had given me an opportunity, or let us know about an opportunity to get involved in research projects. And he kind of pointed me in one of two directions. There was an opportunity to work in biomechanics or in physiology, and I am not very good at physiology at all. So I decided to go the biomechanics route and found an opportunity to work with Dr. Stuart McGill as an undergraduate research assistant, and really got bit by the research bug and loved it from the get-go. Ended up then doing my master's, or continuing my work with him for my master's, and then made the major jump across the hallway to work with Dr. Jack Callahan in his lab at UW, and got a few additional experiences working with more in vivo data and in vitro data during my PhD.
Well, that's really cool. Perhaps that's where I first came across some of your work, was with Dr. Callahan and Dr. McGill. I've certainly read a ton of their research, and subsequently, certainly reading your work, I've been fascinated by the types of things you do. And so I'm so excited to talk about some of these studies today, but I still want to learn a little bit more about your past, and you're currently at the Canadian Memorial Chiropractic College. So I'm curious how you made the jump from Waterloo to CMCC and doing research at a chiropractic school.
Again, that's another interesting story. And then there was kind of a little stop along the way in my path from UW to CMCC. Towards the end of my PhD, I was contemplating either going on to a postdoc or becoming a responsible adult and looking for a job. And I actually ended up following the path of one of my lab mates and began working in an industry at a forensic engineering firm. This was kind of as I was finishing up my PhD. And a few months shortly after having defended my thesis, I got a call from CMCC asking if I would be interested in applying for their vacant position as the McMorland Family Research Chair. And it's been a very interesting experience. As you know, I'm a non-chiropractor working inside of a chiropractic academic institution, and there was a really steep learning curve. And so thankfully I had some really good mentors, and still do have some really good mentors within the institution and around the profession that I can lean on whenever I have questions.
Awesome. Now, do you teach in addition to doing research, or no?
Yes, I mainly teach in the graduate residency program. So the graduate residency program at CMCC is a small program for a select group of students, essentially after they've completed their DC degree. I do the odd lecture for some of the biomechanics classes at CMCC, but most of my interactions with the students, at least on the undergraduate side, is through the research projects and the biomechanics research group that you had presented to a couple of months ago. Okay,
cool. Now, what does a typical day in the life of Sam look like? I have a bit of an idea, but why don't you tell the listeners? Because I think they might be pretty curious, and some might even be interested in going on to pursue a PhD and work within chiropractic doing research later.
Yeah, I guess one of the things that really drew me to research at the outset was the fact that there really is no such thing as a typical day. And I think that you've talked about this in the past with some of your other guests. Obviously, with the pandemic, what I do on a day-to-day basis is very different from what I did before the pandemic started about a year and a half ago. But typically, what it means, or what my job entails, is overseeing research projects being conducted both by students and by other faculty, things do change a little bit from being a graduate student to being a faculty member. As a graduate student, as you know, and hopefully most of your listeners also will know, is that your job is mainly to be the person doing the research. And when you move on to become a faculty member, your role really changes to where you are now the one responsible for directing and facilitating that research. So that really is kind of my main role and my main focus right now.
Got it. Now, I know we're going to be talking about measurement today, and I think that all researchers, all scientists sort of get drilled on the ideas of measurement and validity and reliability, and we'll be talking about that too. But not everyone is keen on exploring issues in measurement. They sort of take it perhaps for granted, I guess is maybe the best word. But we're going to be illuminating some of these concepts today. How did you become interested in exploring issues surrounding measurement?
Yeah, I mean, you hit the nail on the head. Measurement is one of those things that, let's be honest, it's not something that funders are interested in. You're going to have a very difficult time getting funding for measurement studies, but measurements are a critical piece of any scientific research or any research for that matter. I really had, when I was reflecting on this, I was thinking that, I had an interest in measurement from a very early time in my research career. I think that really gets back to my joint interests in kinesiology and mathematics. My initial interests were with respect to data handling and signal processing. And just to kind of explain a little bit about what that means is that the data that we collect in the lab, in biomechanics labs, as you well know, is often very useless in its raw form. And what we have to do as researchers or as investigators is go through a number of steps that are required to treat and transform the data into something that resembles, the dependent measures that you see reported in the journal papers. And something that irked me a little bit, or that I come across regularly, or had come across regularly, was the apparent lack of standardization for these procedures, or these data processing or handling procedures. So I developed a natural interest in trying to develop some of these procedures, or standardize some of the handling procedures for the studies that I was doing during my graduate studies.
Got it. Yeah. Go ahead.
Sorry. No, I also realized quite early on that it was possible then to publish these analyses, or these methodological approaches, which again was another benefit when as a graduate student. My interest in measurement have kind of migrated a little bit from this area since starting at CMCC, and we'll talk a little bit about that, I think, later.
Great. Now, you've published in a lot of excellent journals, and I've enjoyed reading them. I certainly haven't read all of your papers, but I've read probably a good chunk of them over the last decade. And you've published in many different fields: biomechanics, chiropractic measurement, for instance. Can you give us just a brief overview, I suppose, of some of the topics that you're particularly keen on, and what interests you the most these days? It sounds like measurement, but you're using measurement in the context of skills that you've learned. So I just like to hear you talk about that a little bit.
Exactly, measurement is kind of a fundamental or a very prominent interest for me at the moment. But if I was to actually describe what my research interests are these days, it's really related to understanding movement, how people move, why people move the way that they do, and kind of connected or tied to the idea of being able to collect data from people as people are performing what has been called functional movements. So these are things like, gait, sit to stand movements, those types of things.
Awesome. I really love the functional aspect of things. Maybe that's why we get along so well. That's what my interests are too, as you know.
It very well may be.
So before we get into the articles, I want to give a little bit of an overview as to some of the basic concepts involved in measurement. There's a broad range of listeners, typically for these podcasts, from chiropractors, probably mostly, other health providers, the general public, and certainly students at the university that I make listen to these. And so they may be listening as well. So I'm going to define some of these terms as we go through, but I think it's important to realize that first, in research or clinical practice, I suppose, in order to tell whether there are differences between behaviors or outcomes that we expect, whether it's back pain or whatnot, we need to measure. And so fundamentally, things come down to measurement. We use measurement as a way to understand things, to evaluate them, and again, to determine differences in any treatments or outcomes. It allows us to provide a degree of precision in this understanding. For instance, Dr. Howarth is going to talk about a shoulder study coming up, and we could document that a patient's shoulder range of motion, let's say to 80 degrees, is a measurement, I guess we could say, and that sometimes clinicians might say, well, it's limited, or we might use other, I guess, more qualitative terms, but measurement can involve a degree of precision, and that's oftentimes what we're going after. In research, measurement is necessary to determine cause and effect, or simply a relationship between two or more variables. Measurement is necessary to document change, and it's used for decision-making in clinical care, more importantly. Health professionals use patient-reported outcome measures such as Neck Disability Index, or clinician-reported outcome measures such as range of motion or muscle strength. And again, we use these things to progress people through care. With measurement, oftentimes we're assigning numbers to variables like range of motion or heart rate. This can be tricky because some constructs are not directly observable, perhaps like the construct of intelligence or health. Others certainly are more directly observable, again, like having someone move their arm through space. So it's important when measuring to have operational definitions. In other words, how the variable is going to be measured. If we're talking about muscular strength, for instance, we could measure with a dynamometer, a fancy tool to get the degree of force being applied to a tool. We could have people lift weights, or we could do manual muscle testing as examples. Furthermore, the usefulness of measurement depends on the context to which the data is accurate and meaningful regarding a given behavior or attribute. And here, reliability and validity, two terms that we're going to be talking about further, especially reliability, are the most basic aspects of measurement. Reliability is the extent to which measurement is consistent and free from bias or error. You can think of reliability as reproducibility or dependability, I suppose. A reliable instrument would perform with predictable consistency. And then validity assures that the test is measuring what we intend it to measure. In other words, the right construct. So both validity and reliability are fundamental to being able for us as clinicians or as researchers to make conclusions. And so hopefully that gives us a little bit of a background to get started. Does that sound about right, Dr. Howarth? Any additional comments about some of those basic terms?
No, I think that you really hit the nail on the head there and did a really good job of kind of defining some of those concepts. There's just a couple of things, though, that I wanted to touch upon, and I think that you mentioned it in the very kind introduction that you gave to me, that the measurements, we're talking about them today in the context of research studies, but they're not necessarily confined to the research domain. Measurements are routinely made in clinical practice. And so as clinicians, being mindful or paying attention to the way in which those measurements are being taken, or understanding something about those measurements and their properties, the reliability and validity, is imperative. The other thing that I wanted to touch on that you mentioned is with respect to constructs and operational definitions for those constructs. And I believe you might have you brought up intelligence as one of the constructs, but in the spaces that you and I deal with in human movement studies, an example of a construct where I can think of at least 3 or 4 different ways of operationalizing it, so being able to quantify the construct, exists. Coordination is a perfect example of that, where I can think of at least 3 different published ways that I've seen coordination operationalized in the literature. So, that was just something I wanted to add to your description there.
Yeah, no, I think that's a beautiful way to talk about it, because as you mentioned, there are so many different ways to measure coordination. And the thing of it is you come away from some of these research papers and somebody's using a measure of coordination. Sometimes I think, did they just come up with this on their own? Because I've never seen it reported anywhere. And then the conclusion goes something like this. Well, the coordination changed as a result of XXX, YYYZ. And you're left thinking about it, this is the first time I've ever seen that coordination is defined that way operationally. So can I be really certain that it changed coordination, or is this something else?
Absolutely. And that's maybe taking us down a slightly different path, not necessarily talking about measurement, but just to add to that, you would hope that the investigators or the authors of that paper would provide some reference or some citation back to a previous paper or some other group that has employed that approach to quantifying coordination.
Exactly. Well, I think all of this discussion so far is got us in a pretty good path to now talk about the research that you've done in relationship to measurement as well. We'll get to a chiropractic related paper too. And so the first study that I want you to discuss is one that's called Investigator Analytic Repeatability of 2 new intervertebral motion biomarkers for chronic non-specific low back pain in a cohort of healthy controls. And this is published in Chiropractic and Manual Therapies in 2020. So, Sam, could you briefly walk us through this paper?
Yeah. Before I get into this particular paper, I just wanted to point out, Dean, that the lead author of all 3 of these papers that we're going to be discussing today were students at CMCC. 2 of them were residents, and the third was an undergraduate student actually at the time. They've all obviously since graduated and moved on. But that was just something that I really wanted to point out, is that the students were the ones that really were responsible for driving these projects. So the first study here really is a collaboration between myself, other researchers at CMCC, and Drs. Alex and Alan Breen from AECC. I'm going to probably defer any questions related to the technical aspects of quantitative fluoroscopy, which this project was derived from. to them. Hopefully they don't mind me doing that, because I am certainly not an expert in that area. But generally, the premise for this particular study is that the quantitative fluoroscopy has been used over a number of years, and from the work that the Marines have done, there have been a number of different measures produced and studies showing differences in some measures between people with and without low back pain, and different pathologies of the spine and that kind of stuff. More recently, they've been working on two particular variables, one called motion sharing inequality and motion sharing variability. And just briefly, based on my understanding, at least, of these variables, the motion sharing inequality is related to the range or the inequality of movement between vertebral levels throughout a motion. So if we're thinking about spine flexion, the underlying premise is that the total motion of the lumbar spine would be reasonably equally divided between the individual vertebral levels, and that would be an indication of low motion sharing inequality. Obviously, high motion sharing inequality would be if there was, excessively large movements at any one level, or discrepant movements between the levels throughout the motion. Motion sharing variability is just the extent to which the motion is kind of more variable. So it's really the standard deviation of the motion sharing inequality. So just to provide a little bit of a definition for those two variables that we're interested in understanding here. The other thing that I understand about the quantitative fluoroscopy process is that there is, in fact, some user intervention that is required. So the process by which the measurements are obtained involves some the investigator to intervene at some point, and this is after the images have been acquired. And so what we were interested in with this particular study is, to what extent does the investigator have an impact or can influence the outcomes. So these two variables, motion sharing inequality and motion sharing variability. And really what we did was we set out to do your standard inter and intra-rater reliability study. So we had our student who marked up or provided an analysis, or did an analysis of 30 quantitative fluoroscopy image sequences on two separate occasions. And then we had a second investigator who had done the same process once. And what we were interested in is kind of what is the consistency between the two investigators, and also within an investigator, how consistent are things. What we were able to find, or what we demonstrated, was that there certainly was not perfect agreement. The intra-investigator reliability was around 0.9 for motion sharing inequality and 0.78 for motion sharing variability. So that suggests that the reliability, at least within an investigator, was pretty reasonable. There was pretty good investigator reliability for the for the motion sharing inequality, I believe, but not so good for the motion sharing variability. And then when you express those reliability estimates, or take those reliability estimates in conjunction with the standard deviations, and you're able to determine the standard error of measurement, which is basically the measurement error induced by the process, or the standard error measurements were in the range of 10 to 30% of the group means.
Got it. So based upon what you found then, what would you suggest would be of some clinical importance or practical importance from the study?
Yeah, so from a clinical standpoint, I think, understanding that the measurements are subject to some kind of variability or some kind of error induced by the investigator. So when you read studies that are, say, comparing between populations, so I'll use patients with chronic non-specific low back pain and comparing them against a population without low back pain. Understanding that those particular measurements that are reported are subject to a number of different errors, not just related to the instrument itself, but that the investigator might have some kind of impact on the errors of those measurements.
Got it. Yeah. So, I mean, something like, I'm just coming up with something off the top of my head, but if an investigator has pain one day, just like in their hand, for example, and they're going about moving this person in the study that you did, that might affect perhaps the way that they move the person or the way that they interact, just as an example. I mean, there's so many things that could impact.
Exactly. And I didn't mention it before, but the process for deriving the data or determining the data that is used to calculate these motion sharing variables inherently involves an investigator looking at a computer screen and digitizing the corners of the vertebral bodies. And so that's kind of what we were interested in, is to the extent to which an investigator is able to repeatably identify those corners. And as you probably know from your experience in clinical practice, these images are not often perfectly crisp and clear images where the borders and the corners of these vertebral bodies are clearly defined, and one person's definition or determination of a corner might be different from another person's. So that's really kind of what we're interested in with this particular study.
Got it. Now, with this particular study, the subjects were in the recumbent or side-lying position, and I'm just going to ask you to hypothesize here, but what do you think the reliability might do when you're encountering people with either pain in one case, or perhaps even checking people in the standing posture?
Right. So I guess the first thing that I'll reiterate is that any questions related to video fluoroscopy and that technique, I'll defer to the Breens because they're much more familiar with that particular technology and instrumentation. When we're talking about comparing between the recumbent position and upright standing, for example, the reason that the patients or participants are laid in a recumbent position is to effectively eliminate the need for the muscles to support the weight of the upper body as it's moving. So effectively, what you're able to do is have these patients or participants laying on their side on a movable table, and the table then passively moves them through the range of motion. And so what you're able to assess essentially are some of the passive characteristics of the spine or the vertebral column. When you go to standing, obviously, the difference there is that now the muscles are required to support the upper body if you're doing any kind of movement away from the neutral posture. And so that will then have an impact, obviously, on the mechanical properties or the properties joint properties of the vertebral joints. In particular, when you activate the muscles, or when the muscles become active, the force produced by those muscles also induces additional stiffness through the joints and can change the way in which the individual joints behave. And I believe that the Breens have done some more work on this. The work that I'm most familiar with is from Deirdre Tayan back around 2007, where they did a little bit of this work in upright standing with population of patients with low back pain. But our discussion in the paper does, in fact, make note of some of the differences in motion sharing variability that have been identified between patients with chronic nonspecific low back pain and the healthy controls during the standing forward flexion.
Okay, that's great. And I'll make sure to put links to each of these articles so interested listeners can check those out for themselves. The next article I wanted to get to was again talking about reliability. This is a really fascinating paper, I think, for researchers and clinicians, particularly clinicians, actually, I think. And this is called Intercession, Reliability of Glenohumeral Internal and External Rotation, Range of Motion Measurements. It's unaffected by use of applied load feedback. And this is in the journal Measurement in Physical Education and Exercise Science, 2020. So again, I wonder if you could tell us about this paper and its significance.
Right. So what I would probably say is that first paper that we discussed, or the paper we just finished discussing, is kind of more related to my initial interests in measurement and how the data is handled or processed after it's been collected. This particular paper or study is more related to, as you mentioned, the clinical utility of some of these measurements. And really, it was kind of an interesting way in which this project came about. So Chris Grant was the resident working on this project, and he had a natural interest in baseball and throwing sports. And in some of our initial discussions, Chris brought up the idea, or the evidence or the literature that said that there was a 5-degree side-to-side difference in shoulder range of motion, I believe it was, that identified a particular athlete as being at greater risk of sustaining some kind of upper extremity injury. And as we're talking about this, he and I naturally came around to some of these issues in measurement. What is the reliability of a range of motion measurement? What is, what are the measurement errors? And what we actually arrived at was that, interestingly, even though reliability estimates, so those are your inter-class correlation coefficients, had been reported, we couldn't find any real reports or estimates for the standard error of measurement, which would tell you a little bit about what you could expect in the way of measurement error. And when we kind of, did our own calculations based on what had been published from the ICCs and some of the standard deviations of these measurements, we realized that really the standard error of measurement was, in fact, kind of within the range of the proposed injury risk cutoff. And so naturally that raised some alarm bells with us. And so we set out to try and see if there was a way that we could, in fact, reduce that measurement error, as well as to determine whether or not our calculations were, in fact, accurate or correct. And so what we did here was we recruited a population of male only, so that's one limitation there, is that this is only in a population of male recreational overhead athletes. And so what we defined as overhead athletes were really anybody that participated in throwing sports. So these are, baseball, volleyball, tennis, softball, water polo, those kinds of sports. And we had participants come in on separate days, so approximately 1 week apart. And we took measurements of their internal and external rotation range of motion at the glenohumeral joint under two conditions. So we had one where the person applying or performing the passive range of motion was provided with some feedback about the amount of force that they're putting in, because obviously, as you know, the more force you put into the joint, the more motion that you're going to get out of it. And so we felt that being able to standardize or maintain a consistent amount of load going through the joint would in some way possibly help us to improve the reliability of the range of motion measurements. The other condition was a no feedback condition. And our hypothesis essentially was that the use of load as a feedback, or providing load as feedback to the person performing the passive range of motion measurements would improve the ICCs, or the reliability, and then which would then result in a reduction of the standard error measurement. Unfortunately, we didn't find what we thought we would find. So the load feedback, or providing the clinician with feedback, did not improve the reliability of the estimates or of the measurements. It also then did not improve the standard error measurement. But if you are able to look at the paper, or look at the abstract, and for the listeners, this one is not discoverable on PubMed, unfortunately. But the ICCs from the no feedback condition were also pretty good, which essentially meant that our clinician was actually pretty repeatable at performing or doing the range of motion measure tasks, or passively moving the participant's arms. So, that might have pointed to some kind of a ceiling effect there, where we really didn't have much room for improvement.
Got it. And by the way, you mentioned that it wasn't discoverable on PubMed. I'll put the direct link to the journal paper so that people can find it in the show notes. So yeah, I think it's a really neat article, and you described it really well. So thanks for summarizing that. I do want to chat about a couple of things that I think have particularly clinical relevance. You'd mentioned that just the 5 degrees that we were talking about shoulder rotation, 5-degree difference that is between left and right shoulder, can mean the difference between estimating a potential future injury or not having a future injury. And then with the results, finding that the standard errors can be, while they are within that range, I guess the standard error did go up to as high as 6, but they're certainly within that range of the 5 degrees. It gets me to asking, I guess, potentially a few questions clinically, and then the way in which clinicians go about doing the measurements. I mean, when you do the study, and I've looked at the paper, it's very particular. It's very explicit. And I fear that clinicians who would never read a paper like this would just go about doing some motions and measuring stuff. I'll just say measuring stuff. And maybe not achieve the level of precision that you would have achieved here. For example, like you had one hand on the forearm, one hand that was stabilizing the scapula. And I think this is great technique. And in the research realm, we spend a lot of time. We have people do practice trials to get practice effects out of the way and, free up their degrees of freedom and get them warmed up and whatever other terms we want to do. But in clinical practice, I can tell you that, when I'm the researcher, I got my research cap on in some cases, right? And I'm thinking about doing all this stuff. And, that takes time. And clinicians bless their hearts, they just don't have that, 5-6 minutes or, even a minute extra, it seems, to do some of this stuff. But I guess fortunately, your results also point to the idea that you don't have to do 100 different measurements either. So anyways, hopefully some of that makes sense. I don't know if I'm just blabbing here, but maybe you can pick up on some of those points.
Yeah, no, you raised several very valid and good points. And certainly, one of the things that I benefit from in these partnerships with the residents is that these are individuals who do have clinical experience. And so, when we design these studies, there always is a conversation about, okay, so how does this relate back to what you might see or do in clinical practice? And so, the way in which we went about performing the individual passive range of motion measures, I feel, is fairly representative of what happens in clinic. Certainly the way in which we measured the range of motion using the motion capture systems were, maybe a little bit more advanced or more sophisticated than what might be done in clinical practice. One thing that's not mentioned here in the paper, and it was really only not mentioned because we would have 8,000 word manuscript, is that we in fact did obtain measures using just your standard goniometer. We also had measures obtained using an inclinometer, essentially using somebody's cell phone. The reason we chose to focus on only one of the three ways of measuring was that really the results ended up all being fairly similar or the same. So when we do design these studies or we come up with these studies, there is always a discussion about kind of how can we make this relevant or applicable to clinic. I wanted to start off with talking about this proposed 5-degree cutoff. And when it was initially proposed, it was stated as a 5-degree difference from one side to the other. So that's, a 5-degree difference between left and right shoulders. And when you actually look at the other papers, nobody ever reports what the side-to-side difference is. They report the mean for the right side, they report the mean for the left side, and then they take a difference of those two scores. And certainly that's equivalent when you look at averages, but it has there is a little bit of a difference when it comes to assessing or determining variability. So one of the things that we mentioned or reported in our study was, in fact, the side-to-side difference, the reliability of those measurements, and the standard error of measurement for the difference measures or the difference scores. You also brought up a few other points about the opportunity or the use of, say, multiple measurements. And something that we did in this particular study was that we had the clinician perform some preconditioning trials. And so what this does is this essentially will normalize or stabilize some of the passive tissue properties. And this is really a throwback to some of the in vitro work that I used to do during my PhD, where if we were to assess the passive properties of cadaveric tissue, we would have to precondition the specimen with a few cycles of loading before we actually got consistent and repeatable data or results. So the idea here was that we would precondition the joint before actually collecting our measures. And another thing that we were interested in here was whether or not we would need to collect multiple trials. So the idea that you would collect multiple range of motion trials from a particular patient and then collapse them to an average, because the idea of averaging multiple trials is that you would kind of get closer to a or you would arrive at a better estimate of the true value of the range of motion. Whether or not you would need to actually collect multiple trials, or if you could just get away with doing one trial, because as you mentioned, time is valuable in clinical practice, and I don't feel that it's often the practice to do those multiple measures. Fortunately, what we found was that the reliability is just as good with a single measure as it is with an average of multiple measurements.
Yeah, that's good news, I think, for clinicians when they're contemplating doing these types of measures, for sure, and to know that the reliability is pretty much the same between let's say $150,000 set of equipment with the cameras and $8 goniometer, for example, that a clinician could forward and put in their practice. So very valuable stuff. I really appreciated reading that, and I appreciate you going through and discussing your findings with us. And I do want to follow up on something that perhaps is not discussed enough as it should be, at least in my opinion, and that is that we could talk about clinicians and that there's variability between clinicians, but there's always variability between researchers and scientists as well. Not all scientists agree with everything, and so this gets me to my next point, which is, and I'll just use an example here in this last year with the emergence of COVID-19. We've seen all sorts of interesting scientific studies come out in the peer-reviewed literature, even non-peer-reviewed. We've seen an explosion of what are called preprints that aren't peer-reviewed, but they get published nonetheless. And we've seen more retractions than I can recall from fairly prominent journals. We've seen countries that have assessed the exact same peer-reviewed literature and chosen whether or not to impose lockdowns or similar measures. We see an implementation of treatment strategies or no treatment strategies. There's tons of variability with, I guess that's my point. There's tons of variability with the way people are interpreting data, measurement issues. And these are coming into full light for just the average person looking at all the news, and we're just bombarded with all of this stuff. So I guess that brings me to my point of how should clinicians or chiropractors, healthcare practitioners try to assess the use of measurement when sometimes the people that are doing the research that they're relying on disagree, and how should we proceed in given situations like that? I know that's a heavy question, so but maybe you can try to answer it.
Yeah, isn't that interesting? That as researchers, everyone has their opinion, and it's a very opinionated bunch that we are. And science is very rarely black and white. There are all kinds of different shades of gray, and when there are shades of gray, that means that things are open to different interpretations. I think part of what you mentioned also speaks to something that we discussed earlier, and that's really that the interpretation can in fact sometimes be dependent upon the process by which the data is analyzed. And I think this is where looking towards some of the syntheses of evidence, so these are your systematic reviews, meta-analyses, can be very helpful when looking at a particular measurement and whether or not it's a good measurement or not. In particular, there are reviews that would focus on properties of measurement such as reliability and validity. Ultimately, though, I think that making measurements in clinical practice is fine. I think that it happens all the time, obviously, but something that might be important for clinicians to understand are, some of the limitations around those measurements, and to really not rely solely on measurements or give a disproportionate amount of weight to them in your clinical decisions. I like to draw analogies back to athletics or the sporting world, and the explosion of the analytic approach to athlete assessment or athlete performance really has driven sport into being reliant on data. And what I would like to probably caution people against is that they don't forget, clinicians, that they don't forget the other pillars of evidence-based practice model, which are their clinical experience and really the patient preference, and not being so disproportionate, or not giving such a disproportionate amount of weight to measurements or data.
Well, I couldn't agree more. I'm so glad you brought that up, because we have to put this in the bigger picture of things. Like you say, with evidence-based practice, we're focused on the science and the implementation of it. And we realize that there's variability in each of those aspects of just the one pillar. And then we certainly have to consider those other two pillars as well. So thanks for bringing that up. I think that's a super, super important point. We get caught up sometimes in the details, and we forget to think about the broader picture of things. So fantastic. There's one other paper I'd love you to talk about. This is a chiropractic related paper, but it also deals with measurement. And it's titled, "Does Manual Therapy Affect Functional and Biomechanical Outcomes of a Sit-to-Stand Task in a Population with Low Back Pain?" This preliminary analysis, also from Chiropractic and Manual Therapies. So I wonder if you could tell us about this paper.
Yeah, so obviously this is an experimental study. It's actually a secondary analysis of a data set that was collected by our colleagues down at Denver University. If you're looking for the paper, you find the paper, those would be Doctors Curry, Nebo, and Davidson. They were really the ones responsible for collecting the data. And I had seen Dr. Curry present some of their primary work, or the primary work from this data set at a conference. And they had made mention of the fact that they obtained or had participants perform a series of tasks. Sit to stand was one of them that we obviously chose to analyze or focus on for this particular project. But they had participants perform a number of these different types of functional movements, both before and after a manual therapy intervention. And the reason that we've phrased it as a manual therapy intervention, and I'm going to borrow terminology from my student who worked on this project, John Carlo. Manual therapy in this sense was a mishmash between both mobilizations and manipulations. So each patient or each participant in this study received 2 mobilizations and 2 manipulations. So when we're looking at the outcomes, the changes in both the biomechanical and the functional outcomes, we really can't relate them specifically to one intervention or the other. Really, all we can say is that there was a difference that occurred following this intervention, which was a combination of the mobilizations and manipulations. As I mentioned, this was a secondary analysis of data, and really it was the intent was to see if there were functional changes that might occur following manual therapy, and really related to the hypothesis or the theories that manual therapy affects supposedly discrepant neuromuscular control and movement that's observed in people with low back pain. Certainly there's been a number of neurophysiological studies showing things like increased motor drive and force outputs, changes in rate of force production in muscles. following manipulation. But really, it still remains unclear if the manual therapy affects the ability of people to perform or control movements in daily life. And so this was a convenient data set to do an analysis with. Obviously, given that this is a secondary analysis of some existing data, I think that it's worth mentioning there should be probably some follow-up to see if that we can in fact replicate these results. And the results really found that after the manual therapy intervention, the patients who were in this study used a larger amount of sagittal plane range of motion, so that's in the flexion extension axis, after the manual therapy intervention. Also, the amount of time it took them to stand up from the sitting position decreased. And so if you're thinking about a 5-cycle sit-to-stand test or the 30-second chair stand test, obviously decreasing the amount of time to change or transition from a sitting posture to a standing posture would be perceived or interpreted as an improvement in function or an improvement in functional capacity. What I should also mention is that the participants in this particular study did not complete one of those two tasks that are used more in clinic, which is the 5-cycle or the 30-second chair stand test. Instead, they only completed a single sit-to-stand movement, which was basically having a participant stand up from a seated position. The changes are relatively small. And so when we talk about measurements and measurement errors, the overall increase in lumbar sagittal range of motion was only 2.7 degrees or just over 2 degrees. And obviously the time to completion of the test was a single cycle was 0.4 seconds. And if you were to look at the variability of those measures, the variability is obviously within the range. Nonetheless, it was statistically significant. However, the functional significance or the functional importance of these findings is something that maybe would be elucidated through further study.
Great. I really appreciate you going through this. I'm totally biased, I'll say, toward this kind of investigation. My research is particularly geared toward looking at behavioral or macroscopic level of analysis, what people do, their daily activities. And I think there's a lot of things that our research can do in this space. So when I saw this, I was super excited by it. And there's a lot, as you mentioned, there's a lot of, research that I think could be done in this area, but it was great to see this. And I think a fantastic secondary analysis of a data set that you had. And in this study, you used research grade motion capture as well, fairly expensive type of system. And in society these days, there's all sorts of plethora of gadgets and technologies that we're faced with. I was hoping that we could have a conversation a bit about that, about all the measurement tools, if you will, or gadgets that are out there. Some of them are not very expensive. Some are super expensive. Practitioners are buying these things, whether there's great research or not. And then I guess the question is, what will some of these technologies offer clinicians? Are they going to be useful, or are they just going to be a fad type of thing? So lots of things to think about. And in our context, we were talking about reliability, validity. There's, when clinicians go to purchase these things, I would highly recommend that they consider some of these measurement properties that we've talked about today before they spend their hard-earned dollars. But I'm curious what you think, Dr. Howarth, about this idea of all the amazing amount of stuff that we're subjected to with technology these days.
Absolutely. I mean, it's astounding the uh, the accessibility or the availability of this type of technology. I think back to when I started in research and what existed at that point, even just kind of 15 years ago, and none of this would have been possible, uh, 15 years ago. But it seems that the technology is advanced to the point where really motion capture systems or motion capture technology, EMG systems, they are in fact accessible to clinicians. And certainly there are countless number of systems and instruments that can provide people with an unimaginable amount of data. So there are obviously a few things that I think practitioners may want to consider before they decide on exactly which tool might be right for them, and really even before they decide on what is the right tool. I think the first question that someone should ask themselves is what is the intended purpose of the tool, and how might those measurements that come from that device impact their particular practice and the management of their patients. The second thing is the cost of these devices. That obviously has to be a consideration. You mentioned, these motion capture systems or motion capture suites that we use in research, and how they cost in excess of $100,000. But you can purchase a couple of inertial motion units at relatively cheaply or relatively inexpensively. And then you would obviously have to get some software as well to go along with that. What I would also urge practitioners or anyone looking into some of these lower cost systems, or trying to embed more measurement devices in their practice, is to really do some research on the device. Anytime you listen or talk to a company rep about their product, they'll tell you exactly how it's the most appropriate thing for them or for you. But what you need to be aware of is that selling you on their device is a part of their job. And so I think that being critical of the device and trying to dig and understand it a little bit more is important. So think about reaching out to some of the colleagues or researchers that may have in fact used that particular device. Ask them what their experiences have been like. What are some of the limitations of it? What did they find that they liked about it? What didn't they like? Those kinds of things, because really that information could be very valuable. And then if you can, also check the technical specifications, or request a live demo to trial the instrumentation. This is something that I will routinely do if we're trying to incorporate a new piece of equipment or new piece of technology in our lab, is that I will ask the company, can you give me a loaner for a little bit, and can I demo it? Or can you bring somebody in and give me a demonstration before I actually make a decision on this? Because they're major investments, or they're substantial investments. So you want to make sure that you do your due diligence and make sure that you're getting kind of what is the right thing for you.
Sam, those were great points. I really appreciate that, because the last thing I'd want somebody to do is go out and spend a bunch of money on something that's not going to get them towards their purpose, towards whatever they're trying to measure in their office. So I appreciate you going through all of that. Sam, what kind of studies are you planning in the future here? What's capturing your attention these days?
Yeah, so I guess COVID's really thrown a wrench into everyone's lives and everyone's plans. We've had the lab shut down for the better part of the last year and a bit. We're just now starting to kind of get things opened up and running again with data collections. So that's quite exciting. In particular, we're looking at continuing some of these studies focused on movement and looking at changes in movement patterns post-treatment, as well as trying to understand, what I said at the outset, understanding a little bit more about kind of the constraints on people's movement and how people organize their movement strategies or their movement solutions. Because effectively, whenever you're asking somebody to perform a movement task, that is what is often referred to as a movement problem, and it's subject to some constraints that are imposed on that person, either internally by themselves or by the experimenters. Where we're trying to tease out some of the interactions between those task, environmental, and personal constraints. So those are kinds of the in broad strokes, I guess, are the studies that we're planning on pursuing in the future.
That's great. Yeah. Again, I'm totally biased toward that. So I look forward to reading all of these great studies that you'll be producing here in the future. So I'll keep in touch and probably be asking you for copies going forward. So appreciate that. So Sam, a goal of this podcast, as you may know, is to motivate and assist practitioners and students alike to at least consider a career in chiropractic research, if nothing else, just to broaden their horizon and learn more about the science of things, stuff that they, incorporate into practice, like range of motion and the types of things sit to stand that we talked about today. Can you offer any advice to aspiring chiropractors, health professional students who wish to become scientists or researchers in the future?
Yeah, I love that question that you asked, Dean. And, having listened to some of your previous episodes or previous podcasts, I knew that this question was coming. And so I really don't think that my advice is any different or greatly different from that of from your previous guests. If you have an interest and you want to become involved in research, reach out, ask people questions, get involved. Don't figure out ways to contact a researcher or get involved in doing research. And it can be even as simple as, for students, they're often our participants in a lot of our studies. Volunteer to be a participant in a study. Just find ways to get involved. If you're looking to actually conduct research projects, don't be afraid of what might appear to be a very steep learning curve. That learning curve, it can be rather steep, but understand that there are people that you can reach out to and that you can lean on for some kind of guidance and assistance. And as researchers, faculty researchers, that's part of our goal or part of our job is to help mentor and guide people to be involved in research. Researchers, we may be a bit of an awkward bunch, but we're not scary people, or at least most of us aren't. And by and large, I find that researchers are genuine in their willingness or desire to help. The only kind of caveat that I would possibly provide to this kind of advice is that research is not something that, or certainly is something that demands a lot of attention and a commitment. And so make sure that if you are to pursue or get involved in research, that you think about it ahead of time and go in with your eyes open, understanding kind of what the commitment entails and what's involved there.
Well, Dr. Howarth, this has been a real pleasure of mine to have you on the podcast. And I appreciate you taking the time out of your day to educate us and the listeners as to the things that are related to measurement, some of your studies, ways that we can incorporate this into practice, and some some cautions, if you will, of what we may want to look for or not look for in terms of the cool technologies that are out these days. Some of them are cool, but may not be useful. Some of them may be really useful, and you may not even know about them until you do a little bit of research and trying to find the right technologies that meet your demands. So thank you again for everything that you've shared with the audience.
Oh, no, thanks so much for having me on, Dean. I think that, it was really, really fun, and I certainly appreciate it.
Thanks for listening to Dr. Samuel Holworth on this episode of Chiropractic Science. I look forward to bringing you more great episodes in the future.